Good evening, students. If you have joined in, please let me know if the audio and video are fine so that we can start ahead. So, welcoming you all to the MDS 360 degrees MCQ edition. Today, we will be covering the subject of oral and maxillofacial surgery. We'll see a few MCQs specifically of those topics which have been covered in the 360 degree series prior. All right. So, we will start. I'll start reading out the MCQs to you one by one along with all the four options. I'll give you a few seconds to answer the questions. While answering, please mention the question number along with your answer so that I know which question you're answering specifically. And in case you have any doubts, please put down your doubts in the live chat below so that they can be addressed during the live session. All right, so let's start. Coming to question number 1. According to Pedersen's difficulty index, what is the difficulty level of an impacted tooth which is horizontal, visualized as class 3 and position B? So in this question, what you're supposed to do is you're supposed to do the scoring, and as per the scoring, figure out whether it is a minimally difficult or easy tooth to extract, moderately difficult, extremely difficult. So let's see. Now we know that for Pedersen's difficulty index, there are 3 things into consideration. All right. One is the angulation, which is mentioned. Right. Pedersen's difficulty index. It says horizontal. Okay. It says class 3 and position B. Okay. So horizontal is given a score of 2. Class 3 is given a score of 3. And position B is also given a score of 2. So this makes it 7. Okay. Now let's see our Pedersen's difficulty index. So the first one, as I told you, is your Winters classification or angulation, and the Pell and Gregory classification cum difficulty index. They are combined together. So for the Winters classification, we have mesoangular, horizontal, vertical and distoangular. Now I'll give you a easy tip how to remember this sequence. Please remember, many happy vampires dance. Okay, so mesoangular, horizontal, vertical and distoangular. All right, and in this particular order they are scored as 1, 2, 3 and 4. This is one portion which we are not able to remember. The Ramus relation and occlusal relation we are anyways able to remember easily. Okay, now Pell and Gregory classification, we have the Ramus relation and occlusal relation. So Ramus relation is class 1, class 2, class 3. Easiest, intermediate, most difficult, again as per the class. If it is class 1, it's a score of 1. If it's class 2, it's a score of 2. If it's class 3, it's a score of 3. All right. Similarly for occlusal relation as well, position A is scored as 1, the first alphabetical letter. Position B given a score of 2. Position C given a score of 3. Okay. Now when you sum this up, your scores can be categorized as per this following table. So 3 to 4 is easy or minimally difficult, 5 to 7 is moderately difficult, and 7 to 10 is extremely difficult. but whenever the 7 is an overlap score. All right, some older texts used to consider it as moderately difficult, but the newer texts give preference of 7 towards extremely difficult. All right, even though it's an overlapping score, the preference would be given to mark extremely difficult. Okay, so getting back to our options, option C, extremely difficult, is the correct answer. Okay, so I've given you a mnemonic also, I've given you the table also. These are the most important things that you need to remember. All right, let us see our second question. WOF assessment includes all of the following except A. Winter's classification, B. height of the mandible, C. angulation of second molar, and D. root size. All right, so I'll just give you all a few seconds. If you are live with me, if you joined in live, please try and answer the question so that you build confidence. Don't worry, even if you answer wrong here, this is not your exam. I'm here to correct you, to guide you. So even if you're answering wrong, you will understand and retain better when I correct you. So if you all can answer in the chat box, what would be the answer to this particular question? Okay, I have one answer by AJ Style. Anyone else who'd like to answer? Okay, so Winter's classification is included in WOF's assessment. Height of mandible is also included in WOF's assessment, and angulation of second molar is also included in WOF's assessment. Root size is not included. So this is the correct answer because the question is asking WOF assessment except, not, true, which would automatically mean false. So you have to concentrate on your question. Read your question carefully and then answer. All right, what R stands for is actually root shape and development. In WOF's assessment, R stands for root shape and development. So we'll quickly go through the WOF's assessment. W is for Winter's classification. H is for height of mandible, which is measured from the interdental septum between the second and the third molar to the inferior border of the mandible. A is angulation of second molar and not the angulation of the third molar. It's given wrong. Please correct it wherever it is given wrong. R stands for root shape and development, like I just mentioned. F for follicular size and E for exit pathway. Okay. Coming to the third question, what would be the difficulty scoring for mesoangular class 2 position C, mandibular, third molar? So in this question, you just have to score. You don't have to comment on the difficulty. You just have to score. So quickly, please score this and let me know your answers in the comment section. Take a minute to score and do the scoring here itself during the live discussion. You will develop speed while scoring. You can You can refer to the scoring also and do the scoring. Do we have any answers? Okay. So let us see. What is given in the question? Mesioangular, class 2, position C. So for the angulation, I told you, many happy vampires dance. So mesioangular M is given a score of 1. Class 2, you give a corresponding score of 2. Alright, position C, it's the third letter in the alphabet, it is given a score of 3. These are tricks to remember. Alright, so the total is 6. Alright, so the correct answer is option A, 6. Okay, good. Who's all of got this correct? Very good. Now coming on to our next question. Blurred and narrow inferior alveolar nerve canal seen in radiograph along with darkening of root tip. What does this suggest? A. Canal passing in the vicinity of roots. B. Canal is shadowing the roots. C. Root is perforated by the canal. D. There is no relation between roots and canal. So any one of you would like to answer this question? I'm waiting for your answers. Come on, I need answers. Whosoever has joined in live, please give me your answers so that it is more interactive and you can gain confidence. Okay, so it says blurred and narrow inferior alveolar canal seen in the radiograph in a radiograph along with darkening of root tip. So basically the question is telling you certain Rood and Shehab criteria. Alright, based on this you have to judge whether what is the relationship of the root and the canal. Alright, let us quickly see. So we all are aware of Rood and Shehab criteria. Most important things that we need to remember now. Alright, so it says darkening of root. Okay, absence or blurring or interruption of cortical line of inferior alveolar canal. Okay, and sudden deflection or diversion of mandibular canal. Alright, so these are your high risk criteria. So if two high risk criteria are present on your radiograph, that means roots are perforated by inferior alveolar canal or inferior alveolar canal is passing through roots? Okay. So the correct answer is root is perforated by canal. Alright, this is the correct answer. Okay. Alright, so Rit, I hope you have identified, it is clear to you now, the confusion is clear. So Rit, you can let me know in the chat box if you have understood. Coming on to our next question, what is the preferred surgical treatment for ameloblastoma which is extending down to the inferior border? Option A is enucleation, B is resection and reconstruction, C is marsupialization, and D is en bloc resection. So please answer this question for me. Please mention the question number along with your answer so that it is easy for me to recognize which question you have answered. Please mention your answer along with the question number. And quickly tell me what would be the answer to question 5. Alright, very good, Saurit. Please answer this question. On your screen, question number 5. So let's see. The question is saying preferred surgical treatment for an ameloblastoma. Okay, they have not mentioned the type of ameloblastoma which is extending down to the inferior border. Alright. Now this means either it is very near to inferior border or it is involving the inferior border. Alright. So in this case, the question is indicating that we will have to sacrifice the inferior border. Alright. And when we cause a discontinuity or disruption of anterior border, then it becomes segmental resection. Alright. Also sometimes simply known as resection. Okay. And when you cause a discontinuity or disruption in inferior border, you will have to reconstruct or restore the inferior border. So the correct answer is option B, resection and reconstruction. This is the correct answer. Alright. So what I'm trying to tell you is you have to pick the information from the question carefully, read your question carefully, try and figure out what the question is trying to tell you, and then proceed accordingly. You are not supposed to immediately jump to your options, read them and mark in a hurry. You will end up doing mistakes. Alright. Okay, very good. Correct answer. Now, coming to question number 6. A 5 cm suspicious looking lesion of oral mucosa should be A. Incised and sent for biopsy, B. Excised and sent for biopsy, C. Should be aspirated, D. Palliative treatment should be offered. What would be the answer to this particular question? question number 6? Please let me know in the chat box. All of you who are live with me, please answer. Okay, very good. So I have a few answers. Yes, so let's see what does the question say. A 5 centimeter suspicious looking lesion. Suspicious looking lesion means it is definitely not looking benign. It is suspicious for malignancy. Alright. So whenever the lesion is more than 2 centimeters and it is suspicious looking, we go for incisional biopsy. Yes, very good. Spidey's vlog. More than 2 centimeters, we go for incisional biopsy. So, more than 2 centimeters, suspicious looking, incisional biopsy. Less than 2 centimeters, we always can go for excisional biopsy. Alright, so the correct answer here is it should be incised and sent for biopsy. Alright. Okay, great. Saurit, I hope you have understood. I hope it is clear to you now why the answer is A. Please let me know if you've understood or not. Coming to question number 7. Tissue specimens removed for microscopic examination are immediately placed in A. 10% ethanol, B. hydrogen peroxide, C. 10% formalin, D. eugenol. Please let me know the answer to this question. I'm waiting for your answers. Okay. Okay. Very good, Saurit. Now let's come and discuss question number 7. Tissue specimens. They're asking you tissue specimen. Please pay attention. They have not specified the type of tissue, whether it is a soft tissue, whether it is a bony tissue. Alright, but they have definitely mentioned microscopic examination. Alright, the answer here is option C, that is 10% formalin. Now, whenever a tissue is removed from the patient, alright, whenever the tissue is removed from the patient, the tissue starts undergoing autolysis and bacterial attacks. So to prevent all of this, we use certain agents or place the specimen in certain materials known as fixative agents. What do these fixative agents do? They arrest the process of autolysis and bacterial attacks. Now, in different scenarios, the fixative agents are different. Here is a table. You can take a screenshot of this, or you can come back to this later. We will see one by one. So if it is a soft tissue, for general histopathology, the fixative agent is 10% formalin. If it is electron, if the specimen is to be sent for electron microscopy, you will put it in glutaraldehyde. If the specimen has to go for immunohistochemistry or IHC, you will use zinc formalin or formalin which contains zinc salts, or you will use paraformaldehyde. Okay. If the specimen is for cytology, or you do a brush cytology, especially like for oral lesions when you do a brush biopsy, or you do a FNAC, that is fine needle aspiration cytology, then in that case you will use 95% ethanol or methanol or spray fixative. Spray fixative is also alcohol based. It is alcohol with polyethylene glycol. What is a spray fixative? Suppose you have taken a brush biopsy from an oral lesion, and now you have prepared a smear from that specimen onto a slide. Okay, so what you do is, spray fixative is available in spray form. You just spray that fixative all over the slide so that the tissue gets fixed. All right. Bone or calcified tissue is also fixed with 10% buffered formalin followed by decalcification. Frozen section, especially intraoperative frozen section, you use no fixative, and you can use normal saline to transport the specimen to the pathology lab. All right. Now, sentinel lymph node biopsy. If it is being sent for routine histopathology, then 10% formalin. If you are getting a frozen section done for sentinel lymph node biopsy, then again no fixative, use saline. All right. Some important points that you need to remember. So if your question asks soft tissue, or if it asks regarding bony tissue, if it asks regarding frozen sections, please answer accordingly. All right. Now coming to question number 8. A 26-year-old female patient upon examination by you is found to have a fibroma over the floor of mouth, which measures approximately 1.5 centimeter onto 1 centimeter. What would be the recommended biopsy? A. Punch biopsy, B. Brush cytology, C. Incisional biopsy, D. Excisional biopsy. Now please answer this question. And please mention the question number along with your answer. More answers, please. I'm waiting. Very good. Okay, great. So, two things. You encounter a fibroma over the floor of mouth. Okay. Fibroma is a benign lesion. Fibroma measuring 1.5 centimeter into 1 centimeter over the floor of mouth. So the correct thing to do would be a excisional biopsy. Option D is the correct answer here. All right. Yes. Very good. All of you have got this correct. I'm very happy. Coming to question number 9. What type of distraction osteogenesis does not involve transportation segment? A, bifocal, B, unifocal, C, trifocal, D, all of the above. Please answer this. Question number 9, answers please. Try to answer. Even if you get it incorrect, no worries. Don't be afraid. Okay, I have one answer. Two answers. Very good. Very good. Alright. So the correct answer is unifocal. Now for those who have not understood, I'll explain with the help of a visual. Okay. Fine. So unifocal. When we say unifocal distraction is, we osteotomize, there is a single osteotomy, okay, and we pull the bones apart. Alright, so we osteotomize this and pull these bones apart. This is unifocal. Alright, now second thing is bifocal. Okay, now bifocal and trifocal are actually used for defects, are used to cover defects. Alright, alright, let's suppose this is the defect. Alright, the one that I've drawn with orange. Let's suppose that is the defect. Now you want to bridge that gap, you want to reconstruct that defect, you want to regenerate bone in that defect. So what will you do? On one particular edge, you will do the please see, you will understand. You will do the osteotomy at one end. You will do osteotomize the bone at one end. So now there will be a disc. This bone, block of bone will be separate. You will attach distraction device between these two and you will move this towards the other bone so that it goes and joins the other bone, and new bone is forming in between this transport disc and the host bone. Okay, similarly for a trifocal one, suppose you want to bridge this gap, alright, and it's a larger gap. What you do is you osteotomize the ends of both the bones. Alright, so you get two transport segments. And you place distractor devices and move them towards each other, and that dark gray solid shaded area is where you are forming your new bone. Alright, so unifocal does not have a transport disc, bifocal has one transport disc, and trifocal has two transport discs. I hope this is clear to everyone. Please let me know in the comment section. In case anyone has not understood, please let me know. I'll explain again. I'll wait for a minute so that you all let me know whether you have understood or not. And once everyone has understood, I'll erase all these markings so that when you come back to the session, it's easier for you to identify. Okay, so I'll explain again. I'll explain again. Okay, let's see. So what is a unifocal distraction? You did an osteotomy, all right, single osteotomy you did between two bones, all right, or you osteotomized the bone into two, all right, you pulled both the fragments apart and new bone forms in between them, all right. So you did the osteotomy, moved apart, and this is the new bone. Okay, let's see in bifocal. Bifocal and trifocal are specially used to cover defects, all right. Suppose if there is a discontinuity defect in a bone, so you are trying to cover up that defect, regenerate bone, reconstruct that bone, and restore the contour or eliminate the defect, all right. So now what you do in bifocal is you do an osteotomy, all right. You do a osteotomy only at one end, so there you now have a transport segment. You put a distractor device here so that this transport segment goes and joins the other bone and new bone is formed. It will also keep forming as the transport segment keeps moving forward. Okay, this is bifocal. Fine. Trifocal. You do the osteotomy at the ends of both the bony edges, all right. So you get two transport discs or segments. You put distractor devices here and you move them towards each other, so they will come and join, and behind them they will keep forming new bone. Okay, is it clear now, Samriddhi? And everyone else also, please let me know if this is clear. If you all have understood this, then we'll move forward to the next question. Please remember, unifocal does not have any transport disc, bifocal has one transport disc, and trifocal has three transport discs. Sorry, trifocal has two transport discs. Okay, very good. Others understood? All right, very good. Any doubts, please let me know now. We'll move ahead. Great, very good. Coming to question number 10, which of the following is true about distraction osteogenesis in children? A, rate of distraction can be decreased. B, latency period is less. C, distraction is not recommended in children. D, rhythm of distraction needs to be adjusted according to age. So, which of the following is true about distraction in children? Please let me know the answer to this question. Very good, Nimisha. More answers? Yes, so the correct statement amongst the given option is latency period is less. This is the correct answer. All right. I have given you all a table in my live classes comparing the different phases of distraction between children and adults. Please go back, revise that table. That table is important. It helps you solve a lot of questions. We'll quickly see the phases of distraction in children. So latency period is decreased 2 to 4 days. Rate is increased 1.5 to 2 mm per day. Rhythm is not dependent on age, and consolidation period is reduced, that is 4 to 8 weeks. All right, is it clear? HS, have you understood the question? Have you understood the question? Have you understood the answer now? HS, please let me know. Nimisha, have you understood? All right, very good. HS, Nimisha, have you understood? Why is the answer option B? No, distraction is not age dependent. HS, distraction can be done for infants also. It can be done for a few weeks, few months old baby also, and it can be done for elderly people also. Distraction is not age dependent. The rhythm of the distraction is also not dependent on age. We can do distraction osteogenesis procedures for a small infant, few weeks old child, few months old child, up to geriatric patients. All right, so it is not dependent on age. Also the rhythm of the distraction, all right, that is also not age dependent. All right, very good, Namisha. Hope your doubt is clear. HS, please let me know. We proceed to the next question. Coming to question 11, which nerve is near to mandibular third molar mesial aspect and is likely to be injured while removing the third molar? A, inferior alveolar nerve. B, buccal nerve. C, mesenteric nerve. D, lingual nerve. Please answer question number 11. So all these points that I'm telling you after your questions, they are all important. All right, even if you'll memorize these points, you'll be able to answer many similar questions. All right, so these small snippets that I'm giving you after every question, please either add them to your notes or wherever you have accumulated your study material. Please add them if they're already not present or if you have missed out on such important specific points. Okay, so yes, the correct answer here is D, lingual nerve. Now just to tell you quickly via a visual, so there are two nerves which are in close relation to the third molar, mandibular third molar. One is the lingual nerve, okay, and one is the inferior alveolar nerve. Okay, now your lingual nerve is present in the on the medial or the mesial aspect. Spidey's vlogs, medial instead of mesial aspect same. Yes, medial and mesial are the same things. Spidey's vlogs, they can be used interchangeably. Medial and mesial are the same things. Alright, now this lingual nerve is present mesially in the soft tissue. Alright, this is present inferiorly and this is present in the bone. Okay, now one very small point which is actually usually not asked at your level. This is a postgraduate thing, but just in case sometime it's asked in the exam. So the lingual nerve is 2.8 to 8.3 mm below the alveolar crest. All right, this is the distance from the alveolar crest, and from the mesial bony margin it is at a distance of 0.58 to 3.45 mm from the lingual cortex, or the bony edge. Okay, so 2.28 to 8.32 mm from the alveolar crest. All right, so this is how it is. Your third molar is related to both these nerves. Okay, so yes, the correct answer is option D, lingual nerve. Coming to question number 12. In lingual split technique, instrument used to split the tooth is A. Chisel, B. osteotome, C. straight elevator, and D. cow horn forceps. Let's quickly answer. We have a total of 14 questions. We are on 12th. Okay, more answers. Come on. Okay. So the answer is osteotome. Now I'll just tell you a few points regarding difference between chisel and osteotome. All right, and wherever there is a doubt in regard to this answer, please correct it. It is osteotome. Okay, now we have two things, two instruments, chisel and osteotome. All right, chisel is mono-beveled, that means it has a single bevel. Osteotome is bi-beveled, that means it has two bevels. Okay, now it is used to remove, cut or chip away the bone. Chisel, it is used to remove, cut or chip away the bone, and bevel is directed towards the bone to be sacrificed. These are both your question points. All right, fine. And your osteotome is used to split or divide the tooth or the bone. Split or divide, please understand the difference. Split, that means to divide the bone into two. Chisel is just used to chip or cut a small portion or remove a small portion of the bone. Alright, chisel is not used to split or divide the tooth. That is only done by osteotome. Alright, so I'll tell you a way to remember as well. This is your chisel, mono-beveled. Alright, and this is your osteotome. Alright, two bevels. Alright, and how is osteotome used? I'll just tell you. Okay, where should I draw? I'll use another color so that you all can differentiate. Just a moment. Is this color visible? Okay, so if this is your tooth, alright, if this is your tooth, so the osteotome aligns like this in the occlusal fossa. Alright, that's how it splits the tooth. You place it on the occlusal fossa, you use a mallet, tap, 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 and the tooth splits. Alright, now this osteotome has been used previously. These days we use surgical burrs, but osteotome is used by very senior surgeons, and it is used by people who are confident or who prefer using an osteotome, or who are used to use an osteotome to split or section the tooth. Alright, is this clear? No, there should be no confusion about this answer now. Okay, if there are any doubts still, please let me know. Very good, Nimisha. Please let me know if there are any doubts still. Okay, so I have a visual also for you all. So this one is bibeveled, and this is an osteotome. Okay, and this one is your chisel. Unibeveled, chisel. Alright, I've zoomed it out. You can see on your screens. And bibeveled, you can see this. Bibevel osteotome. Okay. Coming to question number 13. Very good, Smriti. Coming to question number 13. Which of these is not a treatment alternative for enucleation in odontogenic keratocyst? A. Cornoid solution, B. Peripheral osteectomy, C. 5-fluorouracil, and D. preoperative radiotherapy. Please answer this question. Answers to question number 13, please. Good. More answers, please. Alright. Yes, very good. Preoperative radiotherapy. So, in OKC, we all know that enucleation plus adjunctive procedures is our treatment of choice. I have told you this in my live sessions also, in my live classes. Now, in those adjunctive procedures, we can use cornoid solution, we can use peripheral osteectomy, we can use cryosurgery, we can use thermal surgery or electrocautery. And there are certain studies which are coming up which say that instead of using cornoid solution after enucleation, we can also use 5-fluorouracil. Alright, now 5-fluorouracil, it is an anti-metabolite, all right, and it is a chemotherapeutic agent, all right. The mechanism of action, Samriddhi, is that 5-fluorouracil works on the sonic hedgehog system. It works at the molecular level. It works at the, you don't need to go into the details of mechanism of action, I'll tell you very quickly. And it works at a genetic level, all right. So the genetic pathway of OKC, it works, it targets that, all right. Details are not required, those are postgraduate level things. Just remember this. What are the advantages of 5-fluorouracil? I'm telling you in the next slide, all right. Now apart from this, there is no role of preoperative radiotherapy for odontogenic keratocyst. It is of no use, it is of no help, it does not affect the or treat the lesion at all, all right. Now coming on to the management of OKC. So like I told you, in adjunctive procedures we will have peripheral osteectomy, chemical cauterization, that is corneal solution, and topical application of 5-FU. Same way how topically the corneal solution is applied, you apply 5-FU also. And how it helps, it reduces recurrence, it targets rapidly dividing cells. Like I told you, it is working at the genetic level, so it targets rapidly dividing cells and minimizes morbidities. That means it causes, some initial studies are suggesting, there is no consensus over it yet, but some initial studies suggest that it is less toxic to the inferior alveolar nerve and soft tissues in comparison to corneal solution, and it is cost effective because this is an anti-metabolite chemotherapeutic agent and it is quite easily available, all right. Samriddhi and HS, are your doubts clear? Are your doubts clear, all of you? Please let me know so we move ahead. Coming to question 14, what is the histological nature of bone produced in distraction osteogenesis? A. Endochondral, B. Intramembranous, C. A mix of endochondral and intramembranous, D. Predominantly intramembranous. Okay, Spidey's vlog has a doubt. Marsupialization followed by delayed enucleation decreases. No, for OKC, no, Spidey's vlog, because OKC, as we know, it is a aggressive lesion. It was also previously classified as keratocystic odontogenic tumor. So for OKC specifically, marsupialization followed by enucleation, no, it is not going to decrease the recurrence rate, all right. So for OKC we need a good clearance, that is why we do the adjunctive procedures which are aiming at the microscopic level or are aiming at the daughter cells or residual cells or satellite cysts or daughter cysts. I hope your doubt is clear, Spidey's vlog. Please let me know. I'll discuss this question as well. Okay, so it's asking you the nature of bone formed in distraction osteogenesis, all right. So now the options are endochondral, intramembranous, a mix of endochondral and intramembranous, predominantly intramembranous. The only type of bone formed after DO is intramembranous. Please remember, it is never a mix, all right, and it is never predominantly. Again, if we are seeing predominantly intramembranous, that means we are saying that it is a mix of endochondral and intramembranous, but the higher percentage is with intramembranous. So this is also wrong, all right. The nature of bone produced in distraction osteogenesis is intramembranous. Now a tip to remember this, easy trick to remember this. This is very confusing, I know. So remember DICE. Distraction, intramembranous, crack means fracture, endochondral. So fracture healing is via endochondral. D, intramembranous, that means D is direct bone formation. Alright. And C for crack is, how is this endochondral? Because this is calcification of cartilage. Remember, C for crack, C for calcification, and C for cartilage. That is why endochondral. Cartilage is also known as chondral. Fine. Is it clear? Will you all remember this? I hope you will not forget. That was the last question for today. I hope you all have enjoyed the session. If there are any doubts, please let me know, or else we'll wind the session in another 2 minutes. So this is your schedule for next 2 days. We'll be updating the schedule for the next month very soon. All right, very good, HS. Keep studying, students. All right, thank you for joining in. Happy studying and good night.